So, hey, Kaylin. All right. So just to let you know, I have meetings with all 5 of you today. Kaylin, you're at 2 p.m. today. Elisa, you're at 2:30. Rhonda, you are at 3. Evelyn, you are at 3:30. And then Mimi at 4. And basically we're going to meet on Teams and talk, you know, some about the quiz or exams or whatever is going on, and try and help to get you guys on track. And also to look at, you know, other options, tutoring with Mr. Davis or things like that that might be helpful. All right. Now, because we had a little break, I'm going to go a little longer than 12, only because I really want to, some of this information, there's a lot of chapters to cover. So if you have the books, turn to chapter 14 in your book, which is about preoperative patients, okay? So I want you to, and we went over a little bit of this, of course, when we were doing our class. But of course, I want to go over some of it. So one of the big issues with operations, of course, is all of the safety aspects that go along with that, wouldn't you say? So as a result of that, Joint Commission really looked at developing a plan to reduce and eliminate preventable surgical complications. And that's known as the Surgical Care Improvement Project, and it's actually on page 229. And when you look at this, you can see that there's a lot of potential for, you know, safety issues when it comes to surgery, not just cutting off the wrong limb, but DVTs, infection, on and on and on and on and on. So we have to look at safety measures, and one of the ways we do it is on page 230, which is a pre-op checklist. And it just shows you right there the pre-procedure check-in that you would do. And you might not work in the OR or pre-op, but you still need to be aware of these things because you're the nurse on the med-surg floor that is getting that patient ready for surgery and then probably accepting them post-op as well. So some of the things that you might be working on pre-operatively, there's core measures on page 231, and one of them I want to bring to your attention is removing hair. And we no longer, you know, shave the hair, they clip the hair. That's one way of doing it. But shaving, as it states on page 231 in this box 14.1, talks about that shaving causes skin abrasions and increases the risk for infection. So I do want you to be aware of that, okay? Looking at the history of the patient, you're going to look at whether they smoke, whether they drink. Smoking, of course, can cause respiratory issues. If they're a drinker, they could go into the DTs. You're looking at cardiac issues. They may need to be on what's called a beta blocker before surgery to help lower that heart rate. And they're going to continue that medication during surgery, not actually during surgery, but pre and post-operatively. Looking again, I said smoking complications that can occur. So just being aware, diabetes, of course, all different things in the medical history that can cause a problem. Looking to see what their previous history was when they had surgery. Did they have a problem with anesthesia, for instance? Asking the patient if they've had blood donation, because some people want their own blood, which is an autologous donation. Also, we're looking at minimally invasive surgeries, robotic surgeries, things like that that are becoming more and more popular now. Look at medications and also supplements that can be used to help with wound healing, like vitamin C, folic acid, B12, zinc, iron. All of those types of things are things that we might be giving as well. It talks as well about salvage machines, which to do with machines blood loss. They actually salvage the cells and then give them back. So that's another thing that you might hear about. On the bottom of page 235, we're looking at mortality and morbidity. Morbidity is basically saying what risk factors do these people have? What other comorbidities do they have? Meaning somebody's coming in for a hernia repair, but they've got morbid obesity, they've got diabetes, and they've got hypertension. Mortality is the risk of them dying as a result of the surgery that they're going to have. So just be aware of that. On page 236, it talks about the considerations of our patients for surgery. Like I just said, the cardiovascular status that we're going to look at, I already just mentioned that. You're going to assess their heart, they're going to assess your blood pressure, all of those types of things. You're going to look at their vascularity, assessing for potential DVTs, anything that could be an issue. Report anything to the surgeon, like shortness of breath or chest pain, anything of that nature. Respiratory issues, looking at their smoking history, like I just said, any chronic illnesses like COPD, you're going to make sure that you report all of those types of things. Kidney function, that's a biggie. Knowing what their kidney function is prior to surgery, of course, because a lot of patients develop what's called retention post-surgery and what's called oliguria. Anyone know what oliguria might be? No?
Oliguria?
Oliguria, yes, the way I say it.
Excessive urine?
The opposite.
Oh, that's right.
Yeah.
Lack of urine.
Lack of urine. There you go. Scant amount of urine. You got it. Okay. So let's see what else I want to say. And of course, you're going to monitor the urine output. Neurological stuff, right? Post-op anesthesia can really cause a problem with patients' neurological status. So making sure that they go back to the baseline that they are already at. Those are something that is needed to be done. Assessing their orientation and their level of consciousness, knowing what that is previously so that we can assess what it is going to be post-op. Musculoskeletal, depending on the positioning of the patient during surgery, which they could be in that position for a long time, you're going to assess and make sure that they don't develop any sort of forms of contractures or anything like that. So just be aware of those things. Nutritional status, like I just mentioned, going to be aware, of course, of the fact that certain surgeries can cause malnutrition. So making sure that their nutritional status is great for, as I said, wound healing. Okay. What else do I want to say? Skin assessment, of course, we're looking in, yeah, we want to make sure that their skin is intact or however it was, because again, when they're in surgery, especially for a long time, they can be at risk for skin breakdown. So all of these types of things on page 236 and 237 are important. Lab assessment, obviously you're going to do your pre-op lab work, your analysis, CMP, clotting factors, PT, INR, all sorts of different things. Are they pregnant? All of that needs to be evaluating. Imaging, normally they'll do imaging prior to surgery, whether it's a chest x-ray or a CT or an MRI, to really evaluate what they're doing with that patient. On page 238, there's a nice little chart, 14.3, that is the preoperative patient. So I do want you to be aware of that. And it just sort of says what you're looking for with that patient before they go to surgery, so that you can really determine whether they're safe to go to surgery or not. Okay. Planning and responding. Remember, you don't work in a vacuum. So remember, the preoperative care is working alongside the the pre-op team. Okay, so you're going to collaborate with the other members of the pre-op team, because you're going to be handing over to them, aren't you? Also the patient, right? I think I may have mentioned this a little bit, but the patient, you need to know that the patient knows what type of surgery they're having and what that means, and has a good understanding of it. So on page 238, it talks about it right there, making sure that the patient can explain in his own words the purpose and expected results of the surgery, making sure understand what NPO is, all of those different pieces right there. Making sure that you do pre-op teaching is important, okay? Pre-op teaching might be some of the things that we talked about, like learning to make sure they splint the wound, making sure they use an incentive spirometer, all of those types of things. So let's see. Where else do I want to go? At the bottom of page 238, it says the Joint Commission require that you provide information about informed consent, dietary restrictions, bowel prep, skin prep. All of those types of things are foundational things to make sure that the patient at least goes into surgery on your watch well. Okay. Let's see. I also just want to make sure you understand as well about, because it's highlighted in yellow in this book, along with the things that I suggest to highlight. Definitely this area, the patient has to be informed and involved in the decision. Recognize that the patient has sufficient information to understand all of the bullet points below, which include things like why they're having surgery, the risks and the benefits, and all of those types of pieces. Who's going to be performing the surgery, and on and on and on. At the bottom of page 239, it says, it is the surgeon's responsibility to provide a complete explanation of what the surgery is going to be about. That's your role. That is the surgeon's role. However, it is important that you clarify what has been said by the surgeon. On page 240, there's a lovely example of a consent form. And on page 241, it just talks about the other types of scenarios that you could run into. For instance, if a patient can't write, they can sign with an X. Of course, you can, if you've got somebody who's the power of attorney, you can make sure that that patient, that the power of attorney is utilized in helping to sign for them. What else? If they can't, if it's an emergency type of scenario, you can have two physicians that are not on the case that can actually help with consent as well. A blind patient can sign, but it has to be witnessed by two people. So there's lots of different there that I want you to be aware of regarding informed consent. Being aware as well, making sure that the right area is marked before the patient goes for surgery. Okay, so those are the types of things to be aware of. Let's see, what else do I want to? Okay. Making sure that the patient has the right to initiate advance directives, maybe prior to surgery. They may want to decide on whether they have a DNR before they go to surgery, something of that nature. So all of those pieces need to be planned. NPO, we all know what NPO means. No eating, no drinking, no smoking, nothing by mouth. Now, it may be a case that they're allowed of water because they may have blood pressure medication to go down with them. So just be aware of those things. And it says that right at the bottom there. And it talks about the types of meds that might be incorporated in that, like antihypertensives or anti-seizure medications. Those are the types of meds that they may have to have that medication before they go for surgery because they're at higher risk. Insulin, that may need to be taken, but it may need to be adjusted, especially if the patient is going to be NPO. So just be aware of that. Or then, of course, if they are going to have insulin, they have to have dextrose on board, along with it, an IV of dextrose. Bowel prep might be done. So just be aware of those things. And skin prep as well. It might be that the patient is told a couple of days before surgery that they're going to do something like a chlorhexidine scrub. So just be aware of what those are. And it talks again in yellow, it's highlighted. Hair clipping can be used, but not shaving. And I have seen questions like that come up. Making the patient aware of the different types of drains that they may have. And we're going to talk about different drains later. IV access, you're going to make sure the patient has an IV access before they go down for surgery. And just down here on page 243, it shows the different types of surgical site preps that can be done. On page 244, it has a picture like I showed you the other day, talking about pre-op breathing, making sure that the patient knows how to use an incentive spirometer, and how to cough and splint so that we're not causing evisceration or a dehiscence of a wound, right? We talked about the other day, making sure that doesn't occur. Making sure that we prevent VTEs or DVTs, so they may have compression hose on, and on page 245 it shows a picture of that. Making sure they do leg exercises, and the biggest thing really from my perspective is getting them up as soon as we possibly can, mobilizing that patient. The next thing as well, another piece is anxiety. Very, very anxiety provoking when a patient goes for surgery. And there are a lot of different things we can do to reduce that anxiety, not just medications, but teaching, distraction, communication, making sure the patient has a good night's sleep prior to surgery, if that's possible, things of that nature. And then, of course, instructions regarding making sure you've got the right patient going down to the OR. So on page 247, it talks a lot about the fact you're going to plan for that patient. They're going to wear a hospital gown. They're going to get rid of all of their jewelry. They may wear pneumatic hose or anti-embolic, TED hose, anti-embolism stockings. Yes, they keep the jewelry at home as much as possible. There may be some potential that they may be able to keep a religious emblem with them, but that's to the discretion of the OR. ID band, of course, with all the appropriate information there. They may need a blood typing band as well, removing dentures, removing any, of course, loose teeth or anything that might be loose in the mouth. Any prosthetics need to be removed. Hearing aids, they may allow them actually in the OR suite, but they're going to take those out eventually. Let's see, glasses, of course, are taken off, and removal of fingernail polish as well, okay? And I'm sort of a stickler regarding nail polish or nails or artificial this, that, or the other. Really, it can still harbor infection. I know some people say, well, I've just got clear polish on, or I've got, I don't know, the gel or whatever. But all of those types of things harbor infection. So really the safest thing you can do is not wear any type of polish or anything on your nails. Same goes for the patient. And the other thing is as well, you want to be aware that it could impede reading an O2 sat. Okay. And then preoperative medications, we just talked about that a little bit. One or the other thing as well, making sure the patient voids before they go for surgery as well to prevent an over-distended bladder. Pre-op drugs, I do want you to be aware. It's halfway down on page 247. A common practice for the pre-op drugs to be given after the patient is transferred to the pre-op area. That way the pre-op team really know precisely when that med was given, because a lot can happen between the patient going from the med-surg floor to pre-op. So I just want you to be aware of that piece then. Okay. And then, of course, on page 248, there's another example of the pre-operative checklist. All right. I am going to move on. Chapter 15. I'm not going to deal too much with this because, you know, a lot of you are not really working in the operative area. But I do want to draw your attention to page 253, where it shows an overview of the operative team members, all of them right there. And then on page 245, it shows some diagrams about invasive surgery, which a lot of that is the robotic surgery, which you may or may not have been aware of. So I just wanted to bring your attention to that. They're using those types of things more and more and more. One of the things they do is inject air into the cavity so that they can sort of blow that area up so it gives them more room to work, and that it's called insufflation. So just be aware post-operatively your patient may feel distended secondary to that. Let's see. On page 256 and 257, there is a nice little picture outline of what a person would do to scrub up. Okay? I don't know if any of you have ever had to do that. But this is a really sort of good idea of what you're doing. Basically, it's a different procedure from just good hand washing. It's fairly in depth when you're scrubbing up, gowning and gloving. And normally what you do is make sure that you have somebody who is not clean. They're not a clean person. They're the ones that are going to come behind and tie the ties and things of that nature to make sure that that person who is scrubbed up remains sterile. They normally stand like this as well once they've scrubbed for twofold. It just to prevent them knocking anything and, you know, that they're no longer sterile. It's a good reminder to them. So I just want you to be aware of that. One of the things B, the picture B, shows where they're rinsing and the water actually runs down the arm like that. That's where it's supposed to go, okay? It runs away from you like that. Discussion on the bottom of page 257 and 258, talking about anesthesia. And I know you went over a little bit of this in PharM, but this is just a refresher right here, talking about the different types of anesthesia. We've got inhalation types. We're suppressing the central nervous system, resulting in unconsciousness. We've got IV, of course. A lot of it is a lot more rapid when you're using IV. And of course, there's a much more increased risk of things like nausea and vomiting, cardiac and respiratory depression. We've got balanced anesthesia, which is the use of several different agents that we can use, such as Versed, and then the use of something like fentanyl together, for instance. And then, of course, we've got our spinal blocks, right? Our nerve blocks and epidurals, things of that nature. So that's on page 258. And I do want you to be aware of that. On 259, it talks about the 4 stages of general anesthesia. And stage 1 talks about, you know, the patient begins to lose consciousness, which is what we want them to do, right? They're feeling drowsy, and that usually happens pretty quickly. But remember, they can still hear, all right? People can still hear what's going on. Stage 2 is loss of sensory, and then, of course, loss of consciousness, and they're going to completely relax at that point. They may have irregular breathing. That's where, of course, they're going to be highly susceptible to laryngospasm or anything of that nature. Stage 3 is where basically the muscle relaxant, begins with general muscle relaxation and ends with loss of reflexes. So that's where the patient would be intubated. Stage 4 is basically a danger stage that we don't want to get into, right? Where it talks about they depress vital organs, respiratory muscles are paralyzed, and pupils are fixed and dilated. So we certainly don't want to do that. It does talk, I'm not going to go over that yet. Yeah, on page 260, there is a lot of information. For some reason, a lot of information about malignant hypothermia. Now, last time I had an OR tech, and I think she said she'd never really seen that, and I don't really hear of that much, but it does talk about what can happen in malignant hypothermia when a patient is in the OR. And the bottom line is, I think I don't really feel that I want to go over that too much, because I just don't think it's something that comes up that much at all. So malignant hypothermia basically is a life-threatening condition, and it's a complication of the types of meds that are used in anesthesia, and it can cause things like respiratory acidosis, dysrhythmias, and a very, very, very high body temperature. So of course it can cause hypoventilation, intubation complications can occur, overdoses, the anesthetic can occur. All of these different things are situations that can occur once a patient has been anesthetized, all right? And then, of course, the local nerve blocks, the epidurals, things like that. There can be systemic toxicity of a agent. It can get into the central nervous system or the cardiovascular system. Acting barbiturate is needed for treatment. So there's different types of regional anesthesia. There's a field block where we sort of go around the area and block that area, like dental surgery. You know, I don't know if you've ever had to have dental surgery, and they'll numb it, but that's not the only numbing injection you're going to get. You get one to start the process, and then they'll do several other around that whole area. Okay, a nerve block actually goes in and around the actual nerve that they're going to use, that's affected. That could be for chronic pain. Spinal anesthesia, that can go actually into the cerebral spinal fluid. That can be used for things like abdominal, pelvic issues. And then of course you've got the epidural as well, and that could be, you know, situations like having a child. Okay, so moderate sedation is a term that we use for patients, for instance, that are going to have, say, Versed or Diprivan for, say, a colonoscopy. Maintain their own airway, but there are medications that are very short acting and allow the patient to return to their full senses very, very quickly. So it just talks about it a little bit there. And it also talks about what we mentioned the other day, the Ramsay sedation scale, where we talked about some of these scales that you evaluate. I don't know if I did talk about that. I'm sorry. We're going to be talking about that today. There's a lot of different scales that can be used to assess what level the patient is, both preoperatively, in the OR, and post-op as well. And on page 262, it just shows if you were going to do some sort of form of spinal or epidural anesthesia and where it would go. And then as you are bringing in this patient, and also of course as we're taking that patient out, you're going to ask the patient what is they're going to ask the same questions. What are you having surgery for? Figuring out, making sure the patient knows what is being done, and all of those pieces. And that talks about that at the bottom of page 262. Of course, you're going to ask about allergy, right? And maybe whether they're going to have autologous blood. It talks about the fact that making sure they have the paperwork if they do have advanced directives or a DNR, making sure that paperwork is there or has been signed if it's appropriate. Let's see. Allergies, iodine allergies, making sure that you guys are aware of that in the OR. And then making sure medications that can cause a risk for, say, bleeding. Any idea what medication could cause a bleeding risk?
Heparin.
Yeah, heparin,
Warfarin.
aspirin.
A blood thinner?
Yeah.
Heparin? Yeah.
Yep, absolutely. So on page 265, I do want to just draw your attention to there are different common surgical positions. So it's important for us to just be aware, because like I said, this patient could be in one position for a very long time. And of course, that could cause skin issues or contracture issues or something of that nature. So be aware of that. Let's see, on page 266, it shows the different pieces of assessing the patient in pre-op and also operative, and how the surgical team basically assess that patient and make sure that everything is done correctly and making sure that the patient is going to be safe in surgery. On page 267, it talks, like I just said, about issues related to positioning, which can include nerve damage, all sorts of things like that. So be aware of that. Surgical counts. Anybody aware of what a surgery count might be?
No, ma'am.
You mean a timeout or surgical count?
A timeout is something that they do as well. Yes. And a surgery count is making sure that everything that they have is accounted for, right? So that they haven't left a sponge or a pair of forceps in the patient's abdominal cavity, something of that nature. So they always do a count pre and post before they close the patient up. So just be aware of that. Sutures. On page 268, it just shows you different types of sutures that can be used. Some of them include staples. It could be just like the, what do I want to say? The absorbable sutures. And then, of course, you've got your non-absorbable sutures. And those would be things that actually have to be taken out physically, okay? And it talks about aseptic technique, but I think we've already really talked about that a lot. Okay, chapter 16, and I'm moving quickly through these because my biggest things that I really want to talk about is immunity and skin. Chapter 16, it talks about post-op care. So look at the top of page 271, and it talks about the handoff that is given. And we talked a little bit about making sure that you as the med-surg nurse, or it could be that you're going to be an OR nurse, making sure that you give a great handoff. And a lot of that can be using the SBAR. It might be using another form that they have that is more detailed than that. But anyway, the bottom line is you always have to do a handoff report, and it says it right here: after surgery is completed, the circulating nurse and the anesthesia provider accompany the patient to PACU. So they give report to PACU, and then PACU gives report to you. Okay. It shows a nice picture on page 273 of a post-anesthesia record. And at the top there, it shows that recovery score that I was talking about, the RASS score, showing what the patient can do, what their consciousness is, what their SATs are, all of those things. That's just one example of making sure that the patient is at the level that they need to be in order to go to PACU and then in order to go to the floor or the ICU. And it says right here, the PACU, the readiness for discharge from the PACU by the presence of a recovery score rating of 9 or 10. So that's what they have to get in order to leave the PACU. What else did I want to mention? During the post-op period, at the bottom of page 272, it says the patient, of course, is at risk for a lot of different things: pneumonia, shock, cardiac arrest, clotting issues, and GI bleeding. So many concerns there. Respiratory, it says making sure the patient has a reliable airway. I'm sorry, not a patent airway. And sometimes talking isn't always a great indicator of good gas exchange. Cardiovascular signs. I just want to mention as well in the respiratory, some of the things that you might be aware of that indicate the patient doesn't have good gas exchange are things like stridor, snoring, all of those types of things. Okay, that could be part of the issue. Excuse me. Other indicators could be that they have a hard time, they may have some muscle weakness, okay? So they're not able to expand the diaphragm well. Cardiovascular, in the PACU, they're going to monitor that patient every 15 minutes, not necessarily so on the floor. You might do initially for the first hour, and then it may trend down from there. But anyway, of course, you're going to evaluate blood pressure, you're going to report any changes to the physician, monitor the pulse, the apical pulse, and the differences between the apical and the radial, which is called a pulse deficit, if there is one. You're going to assess the neurological system, the cerebral functioning, get the patient to try and follow some commands, like, get them to wake up, open your eyes, take a deep breath, those types of things. Ask them, if they know their name, what their name is. Oh, excuse me. Oh, I apologize. So anyway, you're going to monitor the difference in the baseline from what they were pre-op to what they are post-op as well. Let's see if there's anything I want to ask you guys. Okay. On page 275, please be aware of the concerns of a spinal anesthesia. Now, we talked about spinal anesthesia, but just be aware of the different of things that can happen with that. Obviously, respiratory depression, the medication goes systemically. Hypotension, blood pressure can drop, a hematoma can occur, infection is a biggie, and they can also get a post-dural puncture headache as well. So just be aware of those things. Headaches are very common with epidurals. You're going to monitor the patient's fluid and electrolytes and their acid base, okay? And so that's why you're going to do their INOs and keep a really close eye on that, their intake and output. And that includes not just literally what they're taking in through the IV. Excuse me, I apologize. But also looking at things like if they're vomiting, NG tube output, drain output, wound output, all of these types of things could be incorporated into it. And sometimes it will, if they're having a lot of wound output, of course, but as much as you can. Hydration, sure there's no tenting occurring, that they are hydrated. Looking at the IV fluids that they might need, making sure they've got a good IV site, making sure that they're not going into respiratory acidosis or metabolic alkalosis, any of those types of things. Metabolic changes can occur, of course, with the NG tube, right? When they've got that excess output going from the NG tube, they could go into a form of alkalosis. So just be aware of that. And it talks about that at the bottom of page 276. Urinary system, some medications can definitely cause retention. So we're going to monitor that urine output, of course. And we all know that that's 30 mils an hour now, right? GI system, many patients post-operatively suffer from post-op nausea and vomiting. So you're definitely going to be aware of that as well. Let me see. I want to see. I think I have a question for you. Yeah. So I have a patient. I have a question for you. Nurse works on a post-op floor. She has 4 patients that are being discharged tomorrow. Who needs discharge planning out of these 4 for post-discharge care? A married woman who is the primary caregiver for children, a middle-aged person who is post-op knee replacement and is just going to get physical therapy, an older adult who lives at home despite memory loss, a young patient who lives alone and has friends and family nearby. Which one would you think would need post-op care or rather discharge planning care?
C.
Ready.
C. Number 3.
Mimi, you say C. Anyone
Yeah.
else say anything different?
C.
It is C. Your old person. Yeah, your older person would be the one. Because
Is that the one with the memory loss?
yeah, he's got a bit of memory loss already, right? So he's post, remember, so that can really affect you neurologically. And of course, with them being older, remember that it can, the older adult, unfortunately, it's going to affect a lot more other pieces as well, more rapidly. So GI system, I said about nausea and vomiting, you're going to listen, you're going to ascultate their bowel sounds, right, for peristalsis. They may not have peristalsis for 24 to 48 hours, but certainly you're going to check for any potential for an ileus. You're going to look at the NG tube drainage. You're going to look at what color it is, how much it is, if it's too much or too little. You know, discomfort, of course, with the NG tube. And as I say, a lot of electrolyte imbalances can occur with an NG tube. So just be aware of that. Hypokalemia, hyponatremia can occur, and metabolic alkalosis because you're pulling out all of the acid. Constipation is a biggie. And then, of course, skin integrity, right? They've got a wound. So we're looking at wound healing for that patient. And it says at the top of page 277 that wound healing can take about 6 weeks to actually 2 years for complete wound healing. And it does sort of just detail the physiology of how that wound is going to heal, which I'm just going to let you read that. But my biggest thing I want to touch on down at the bottom of 277 are 2 things, dehiscence and evisceration. So dehiscence is where the wound, and it shows a couple of pictures on page, it just shows actually, yeah, it shows the differences. On 278, it shows the difference between a dehisced wound and evisceration. So evisceration is where the bowel is going to come out. And so, of course, you're going to put a nice wet gauze on that area, and just, that's an emergency, okay, when that happens. That is an absolute emergency, but I do want you to be aware of it. Evisceration is a surgical emergency. You're going to contact the surgeon and the OR and know. And it says here, dehiscence and evisceration can occur between the 5th and 10th days after surgery. And that is a big issue, I think, because a lot of people have already gone home by the time the 5th or the 10th day comes around, haven't they? At that point, yeah. So
Yeah.
a lot of teaching is involved to make sure they're aware if they feel something pop, or helping them to make sure that they splint if coughing or vomiting or straining. They've got to make sure they do all those things. On page, where are we? 279, it just shows some pictures of different drains. And some you may have been aware of, not. There's things like the Penrose drain and the JP drain, which is the one that looks like a hand grenade. The number C there. Different types of drains, the Hemovac, and basically they either are a simple drain where they go in and drain outwards and the drainage comes out on a pad of some sort, or these other drains like the JP and the Hemovac collect the actual fluid in there, and we drain them out and measure that drainage. Another thing I want you to be aware of course, is pain assessment. I think that's sort of self-explanatory. I don't think I really need to go into a massive lot of detail about that. We've talked about assessing labs. One of the things I want you to be aware of, especially with the potential for infection and sepsis, is a thing called the left shift. We're going to talk about immunity next, but it's a thing called bandemia or left shift. And what that basically is immature neutrophils. You're going to get more of them than normal because the body is saying, oh my gosh, I've got an infection. I need to do something about it and I don't have enough neutrophils. So it starts pushing out these lower level neutrophils called bands. And when you see a lot of them on the white cell count differential, that's usually an indication that there's some infection going on as well. A lot of other things they can do, like lactic acids and things of that nature, but I did want to bring that out. Gas exchange, I think we've sort of talked about that, but of course you're going to be aware of certain medications that depress the respiratory system. And of course, one of them is things like Versed. Okay. They may need, it says here, flumazenil, and I think I've pronounced that correctly, to reverse that. Remember, Narcan is often used for reversing opioids overdose. Okay. It does talk a little bit on page 281 about benzo overdoses and what you would do for it. So pretty much saying what we just said here, but of course you're looking at your ABCs. You're always looking at your airway as a priority in these things. Helping the patient to do breathing exercises, that we've already discussed that. Preventing wound infection is a huge one that we would be doing, of course, looking at that wound for any signs or symptoms of infection. So what sort of things do you think you would be looking for infection?
Look around the wound as
Pardon?
look at the perlinate, make sure there's no perlinate drainage.
Yeah.
Look for redness, look for heat, like to make sure it's not warm.
Yeah.
Pretty much that's it. So
you got it, Mimi. Exactly it. So a patient with a wound or a drain, right? They've got a drain, you're going to do the same thing. So if I said to you a post-op patient with an abdominal drain, what would be the assessment and the priority problem related to that drain? We just said it, right? That there's no redness or warmth or drainage at the insertion site. So believe me, ladies, I am helping you out a lot today. I hope you're taking some notes.
Yes, ma'am.
Just saying. Okay. Sin sutures. Yeah, we could probably do some of those. Skin sutures. Staple up that sin, right? Anyway, skin sutures or staples. Usually they're removed around about, it says 5 to 10 days, but it's usually about a week to 10 days. And sometimes they'll have orders for the nurse to remove those staples or sutures. So there is a specific way of removing staples or skin sutures. Always you want to make sure you're not pulling the suture through the skin. It's that way. So if you've never done it before, you know, maybe what I'll try and do is see if I can find a YouTube video or something. It's not that that's one of those things that you will come across hopefully in your clinicals at some point. It talks about the Penrose drain. Basically, as I say, like this is just a drain that that it's internal, but it has external, and it's on just like a dressing. And they basically, what they do is they begin to sort of cut this drain down as the wound heals. So you may or may not have seen that. I remember seeing that a lot. It's like a corrugated type of drain that you may have seen. Let's see. Wounds that become infected. Obviously, you're probably going to go with some form of systemic antibiotic, whether it's IV or PO. They may need to clean the wound with things like hydrogen peroxide, of course, saline, iodine. They may use a wound vac. Anybody ever heard of vac before? Okay, that might
They use
be
them all the time in a nursing home.
You do, good. Okay. Well, yeah, and some people may not have them, but as I say, wound vacs can be useful for pressure sores or for wounds that have become infected in one way or another. So let's just say, okay, so 283, there's a nice little best practice if you come across a patient that has a wound evisceration. So just be aware of that. Post-operative pain talks about different medications that we can use. Of course, we can use our opioids. We can use NSAIDs. Things like Toradol can be used, ibuprofen, depending on what's going on, of course. Let's see. What else? Couple of things I do want you to be aware of. On page 280, a nursing action. Do not use pillow support under the knee, because what it could do is impede circulation. So just be aware of that, okay?
What page that you say?
Yeah, 85.
Okay.
Let's see. Give me a second. See if there's anything else I want to.
Wait, you said it says do not support, but at the bottom it says support the extremities with pillows. Turn and help the patient turn at least every 2 hours while he or she is bedridden. What part are you talking about?
No. If you look at the action alert in yellow, it says do not place pillows under the knee. That's what I'm saying.
Oh, okay.
Because you've got your popliteal area there, your popliteal vein, and you don't want to impede that, okay? So that's what it's talking about. So you don't actually, yes, you can of course put pillows lower down or things like that, but that space right there under the knee. Does that make sense?
Mm-hmm.
But yes, of course,
ma'am.
you're going to be turning your patient. Yeah. Be aware, complementary and integrated health things that we can do. Of course, there's always different things that we can do to help relieve pain that are non-pharmacological ways. And let's see what else I want to do. Promoting peristalsis. Of course, a lot of patients develop ileuses post-operatively. So we want to make sure that we're monitoring that patient, giving things like hydration. They may need a stool softener. Mimi, you brought that out the other day. Increasing their mobility, making sure that we do the right thing with pain management. Yes, they need pain management, but we're monitoring that using our pain assessment tools and making sure that we're balancing that with helping them to get up, mobilize, and poop. All right. And one thing I do bring out, gum chewing. That apparently helps with peristalsis. I had not heard of that, but it does mention that in the book. So that's sort of a good idea to help, help peristalsis occur. And then, of course, we can use different types of drug medications to help with peristalsis. And again, it talks about the fact that the mu receptors in the GI system are the little culprits that reduce peristalsis. So it just talks about the physiology of that there. One big thing I want to bring out to you is home care management. And this is sort of a biggie with our patients, generally speaking. So just be patients that would need good discharge planning, okay? And let me look through here a minute. Yeah. So things that came up on the HESI, just for your awareness, operative shaving rationale, you wouldn't do it. Why? We talked about it, right? That's why I brought it up to you. Let's see. And post-operative risks. Just be aware of the different risk factors as well, post-operatively, like we talked about. And then finally, I just want to mention, of course, things like the diets that we would use to promote wound healing, protein, calories, vitamin C, zinc, iron, all the things I like to give to people, okay? And then just be aware, of course, with your resources. All right, take a breath, because 11 o'clock, yay, I'm on to immune system. This is, so a lot of what I just talked about right now, just FYI, I'm helping you with your quiz for next week, okay? Really helping you out here, guys.
We appreciate it.
You're welcome.
Thank you.
So remember, here's an example. With your older patient who's hospitalized after an operation, you're assessing your patient for a post-op infection. What priority assessment should the nurse know? A change in behavior, the white cell count, presence of fever and chills, or tolerance of increasing activity?
Fever and chills.
I think it's A or D. What did you say for D again?
A, change in behavior. B is daily white cell count. C is presence of fever and chills. And 4 is tolerance of increasing activity.
C.
It's A.
I was right. Okay.
Now, but let me help you understand now. Older people often do not show a fever first. Often older people may have an infection and you may not see their vital signs change that much initially. The first indicators of a UTI, or any type of infection with an older person is change in behavior. Mimi, you work in a nursing home, right? How many little old people start acting differently? The vital signs might be the same, but they start acting differently and they've got a UTI.
Yeah, that's why the first time they have a mood change, that's the first thing we do is get with the PA and say we needed an order for urine culture.
Exactly. All right. So, you know, I'm making sure that you understand that, because it's easy to say, well, they've got a fever, not with your older person. All right. So just bear that in mind. Let's see what else. I'll give you. Patient's going to have surgery, and the nurse brings an informed consent form for the patient to sign the form. The patient asks about possible complications from the operation. How should the nurse respond? A, answer the questions and document that teaching was done. B, do not have the patient sign the consent and call the surgeon. Have the patient sign the consent and call the surgeon, or the patient of what teaching the surgeon had done.
B.
B. It's B. Okay. Yeah, because obviously the patient doesn't know what surgery they're having. So you're going to call. All right, let's move on to immunity. So on page 290 and page 291, it talks a little bit about immunity. So what we've got here is, I just want to mention to you, it's on page 219. I'm just going to read a little bit here. It says, each person's cells have a unique surface protein that are specific to that person, known as human leukocyte antigens, or HLAs. And HLAs serve as a universal product code for that person, and they're identical only with a sibling. I'm going to stop right there. Later on, we're going to talk about transplant rejection. What type of person do you think would be the best person if you needed a transplant?
Relative.
And you would, based on this?
A sibling.
Correct. No, identical, a twin. Identical twin. So this is why this is important, because each of us have a different genetic code, if you will, right? That basically the body sets up this genetic code in our bodies. The only person that would be a great match for a as a donor for a transplant is an identical twin. Otherwise, you've got this risk going on right here. One adult's HLA are recognized as foreign or non-self by the immune system in another adult. All right. So what happens is non-self, we basically build up these antigens, and then we also build up these antibodies. That's what happens right here. So it says here, because the cell surface proteins are non-self to another adult's immune system, they are antigens. So these antigens stimulate an antibody response. Does that make sense? Okay. HLAs are on the surface of most body cells, not just leukocytes, and this is a normal part of a person and determine the tissue type of a person. So that's our code, our DNA, our genetic coding right there. So I just want you to be aware of that. It says a little bit further down, if the encounter cells HLA match, then then the body recognizes that and it's not attacked. If the encountered cells HLAs do not match, then the body goes into action and sees that issue or tissue or whatever it is, bacteria, on and on and on, as foreign, and goes into action to protect the body. That's what's going on there. The immune system cell then takes action to neutralize, destroy, or eliminate this foreign invader. It also goes on to talk about toll-like receptors. And again, that's another way of assessing self from non-self. Let's see. I want you to look at 291 because it shows the bone, and then it shows inside the bone, inside the bone marrow, what we have. And we have stem cells. Has anybody ever heard of stem cells before? Okay. So off of that stem cell, and I find this fascinating, comes everything else, right? You've got your red line cell, you've got your platelet cells coming off there, you've got your white cells, and that's your all of these other ones right here. That includes things like your T cell line and your B cell line, your neutrophils, your basophils, your eosinophils, your phagocytes, all of those different things come from that stem cell. All right. What I want you to be aware of at the top of page 291 is chart 17.1. And it talks about the immune responses here, talks about inflammation, but below that, it says antibody-mediated immunity. And it talks about the B cells. And I always say antibody, so B, for B cells with antibody, okay? And then below that, it says cell-mediated immunity, and that's actually going to be our T cells, all right? So it talks about what do, and it just sort of mentions it, but I just really wanted you to understand the difference between B cells. B cells produce antibodies, and T cells develop a whole nother line with cell-mediated immunity. All right, so let's just talk a little bit. Let's see where I want to go with this. It says it again on table 17.1. Again, it just reminds you about antibody-mediated immunity, cell line, and then your cell-mediated immunity is your T cells. Now, bear that in mind, because what comes off your T cells? Think about HIV and AIDS, right? That's your T cells. I don't know if any of you are aware that, you know, one of the things we look at, the CD4 amount, the T cells, that's what you're looking at. The less amount of the patient has, the higher the risk they are for developing certain cancers, certain infections, all of those things, all right? Let's see. Talks about inflammatory response at the bottom of 292, and I just want you to be aware of that, because inflammation is our body's way of dealing with something that is attacking us, right? That inflammatory response is critical for health, in fact. It's a non-specific body defense system, but basically all of these white cells go into effect to help start protecting that area. So it just talks about it like that. It says, you know, if you get a splinter, that's going to trigger inflammation or burn or anything else. Infection. Infection is usually accompanied by inflammation, but not always. It could be a blister that you see forming. You might see inflammation without infection, say in a joint sprain or something like that. Rhinitis, anything with an itis is inflammation, by the way. Moving on, I just want to let you know about what mature neutrophils are. And it says here, it talks about it right here. Less mature neutrophils are called bands. And that's where we're talking about that left shift, where basically the bone marrow can't keep pace with producing enough neutrophils when somebody has an acute infection, and they'll start producing out these bands, more and more of them, because although they're immature, the body's like, well, something's better than nothing. So it brings out these bands as well as the neutrophils. So I just want you to be aware of that. Neutrophils, it says it takes about 14 days to produce a neutrophil. Why do I care about that? Well, if somebody is on chemotherapy, when you give chemo, what does it do? It knocks out every cell, right? Not just the cancer cells, but the good cells too. So it knocks down their immune system. Day 14 is where that system is completely tapped, because they don't have those usual neutrophils working like they would, you know, to help protect the patient. So I just want you to be aware of that. Neutrophil function, and why do I care about that? The ANC, the absolute neutrophil count, is exactly what I was just saying. The higher the number, the greater the resistance to infection. So if my absolute neutrophil count is really, really low, guess what? That patient is at risk. Why do you care about that? You should care about that, because when you're teaching your patient about how to protect themselves, say post-chemotherapy or any other scenario where their immune system is reduced, then you want to make them aware of the risks that they could be incurring if they go outside or something like that. I don't need to go into the left shift. I've just already talked about that. Macrophages, we know what, right? They engulf. That's what they do. They're Pac-Man, as I like to say. They engulf everything. They actually are the ones that present the prize to everything else. They engulf it. And they're like, here, blast that. That's what they do. All right, basophils, it just says increased basophils. Basically, you would see an increase in basophils if there is an infection. So I just want you to be aware about that. Eosinophils, you will see a rise in eosinophils if somebody has a lot of inflammation on board. For instance, somebody who has allergies, you're going to see increased eosinophils. Mast cells, just basically these respond to allergic scenarios, and they're actually produced by the T cell. All right, phagocytosis. I think I've already just talked about that. Basically, what happens is this is an engulfing of the foreign body, and it shows it right there. And then basically it's presented so the rest of the team can come along and blast it and kill it. Okay. All right. Talks about on 295 the sequence of inflammation, and I just want you to be aware of the fact that there are 5 cardinal symptoms of inflammation that it talks about. So stage 1, it's showing blood flow to that area, right? Hyperemia, that's what's going to occur. And we want that because we want extra blood flow to the area so that these cells can get there and do their work, right? That's the first thing that we're going to notice, stage 1. This basically also secretes cytokines. Cytokines are the things that basically are the little killers. So cytokines are released. So let me just see if there's anything else I want to bring out in that. Tissue macrophages secrete cytokines. Yeah. One of the cytokines, and we're going to go through that in a few minutes, I think on a couple of pages in. Page 300, but it talks about different types of cytokines. And I find this sort of interesting because one of the cytokines is GCSF, which is a colony stimulating hormone, factor rather. So these types of cytokines actually can help to upregulate neutrophils. So just be aware of that at the top of page 295. Stage 2, again, it talks about neutrophilia. We've opened up that area so blood flow can get in there more and so that the neutrophils can increase in that area, which they will. You will see that. And that's when you're going to see things like pus occurring, right? You've got this exudate, this white going on, which is your neutrophils. Let me see if I want to give you any questions. I will in a minute. We'll see if you're listening. All right, let's see what else. Neutrophils. Under the influence of cytokines, the neutrophil count starts to increase. So that's why when you look at a white cell count and they say things like, wow, their white cell count is really high, that's what's causing it. The neutrophils are causing that increase in the white cell count, okay? Also, as well as these cytokines, you're going to see different things increase, like I can't ever pronounce this well, I apologize. Arachidonic acid starts to increase as well. And with that increase, it converts to what's called a sort of COX is what it's called. And that converts other things to basically, let me just read this because I want to make sure I get this right for you. I highlighted it. Yeah, what we're doing is we're actually wanting to block some of the inflammatory mediators. So what this has done is just blocking some of these mediators that it's actually blocking things like histamine, it's blocking things like leukotrienes, prostaglandins, serotonin, and antikinins. So we want all of those at that point to increase the inflammation so that we increase the blood flow. But what I'm also reading here as well, and that's where my brain got a little twisted, was the fact that anti-inflammatory medications, what they do is they block this action. So I just want you to be aware of that, that's all. Stage 2, what are we going to do? Well, we're hoping we're going to start seeing some types of repair around the tissue. That's what's going to happen. And it talks a little bit lower down about heart muscles. When the heart is in, when there has been a heart attack or necrosis or something of that nature, you're going to get some scar tissue building up, just like you would in any other infected area, right? You're going to get scar tissue building up. So be aware that that happens internally as well in certain things like the heart. And of course, if you've got scar tissue on the heart, for instance, it's going to reduce the how that heart muscle is going to pump, right? It's going to have reduced viability. So just be aware of that. It actually, if 20% of the heart is affected, then 20% of the heart muscle is, its action is going to be reduced. At the top of page 295, there's a nice little picture just outlining the differences between the thymus, and also it says about the thymus tissue, the lymphoid tissues here, the spleen, the tonsils, and also the lymphocytes, and the B cell line and the T cell line, and how that actually works and how they work differently, but also together. So your B cell line, what did I say that ends up? What do you get from your B cells? Anybody remember? B for what?
Is it antibodies?
Yes, B for antibodies. And then your T cells, basically are your killer cells, also what's called cell-mediated response cells, okay? So think mediated, it has a T in it. So T for mediated and B for antibodies. Might be helpful. That's how I remember it. Right, so antibody immunity, also known as humoral immunity, like I just said, they're produced by the B cells, and really our antibodies are produced in various different ways, right? They start as stem cells. Where do stem cells come from? I'm asking you this question. A nursing student learning about antibody-mediated immunity learns that the cell with the most direct role in this process begins development in which tissue or organ? Anybody?
And your bones?
Yeah, but specifically where?
Bone marrow.
Thank you. Bingo. Bone marrow, right? B for bone marrow. B for bone. T for thymus. Thymus is your T cells. All right, but remember B for bone marrow, okay? Now, I'm not going to go into what I just talked about, which was basically the body gets invaded by something, and it shows a beautiful little diagram of a macrophage presenting gem T cells and the B cells, and basically how the T cells and the B cells work together to engulf the thing, clear the body of it, but at the same time then produce what? Antibodies. Okay, that's what it's producing. So next time that the person has an infection of the same type, only of the same type, then the body is able to respond to that and say, you can't come here, no entry. All right. So this is basically what immunity is. Now, I do want you to be aware of a couple of things. And it talks about influenza. So basically, you know, you've got influenza A and you've got influenza B, and we have lots of different types of influenza too. But if you actually are exposed to the one type of influenza that potentially could crop up again, then you're immune to it, all right? Just like if you're vaccinated, anything like that. So it sort of talks about it there. I want you to be aware of what sensation is, and I just talked about it, right? You're sensitized only to that one antigen. Bear that in mind. So, you know, just because you may be sensitized to influenza doesn't mean you're going to be sensitized to, say, pneumonia, all right? So let's see if there's something else I want to bring out on that. Bear with me. I think we're good so far on that. Bear with me. Trying to help you out, guys. Let's see. Okay, I'll leave that. All right, so we talked about antibodies a little bit. On 297, I just want to bring this piece out for you. It talks about the difference between IgG and IgM. You know, you've got immunoglobulins in your body, and a lot of the time what they'll do is figure out the different types of antibody classification. And at the top of page 298, it talks about different types of antibody. You've got IgA, which is your secretory antibody, right? That comes from breast milk. That's one way that that babies receive certain types of immunity. Okay. You've got IgE. IgE is your allergy. People that have high responses to IgE, say to wheat or something like that, potentially could have celiac disease, okay? IgG, basically if you were to do a TB quantiferon test on me and you tested me for whether I've got TB or not, that quantiferon test tests for IgG and IgM. IgM says, whoa, this patient's got a new infection. IgM for immediate, all right? IgG means, they had an infection, but it's gone. It shows that they've got long-term immunity. So I just want you to be aware of these different types of things that may or may not crop up. I'm not saying you're going to get tested on that, because to me, really, that's more of a deeper dive of immunity. But does anyone have any questions about or anything to comment on? Nope. Does that make sense? A little bit?
Barely.
It's a lot. I know, it's a lot. Immunity is hard. It is not hard for sure. Just be aware as well that, you know, our antibodies, we can produce antibodies, like I just said, and we can transfer those antibodies. So we have short-term immunity, i.e. a rabies shot or a tetanus shot, right? That's more of a short-term immunity that we can give to somebody. And of course, we can give immunity to our children as well, through secretory IgA, and of course, different immunity that we pass from mother to child, so to baby rather. So just be aware of that. Let's see, active immunity down at the bottom. So active immunity is more of when you actually have the disease, whatever that is, whether it's chicken, whatever, and you build up an immune response to it, okay? Because the body takes part in that. And then natural active immunity is what I just said. That's actually the longest lasting. Artificial active immunity is an immunization or a vaccine, such as diphtheria or polio or whatever, okay? I actually am one of the people that had a BCG, and that's one of the things that you will tell with most people that live abroad or have come from abroad. We usually have a little mark right here that we've had either a BCG and smallpox as well. Most of us got immunized from smallpox. So I don't know if they immunize smallpox anymore. But anyway, sometimes you're going to need a booster, right? When you do your Hep B, I think it's your Hep B that you need to be done for. Hep B or Hep C, I can't remember. I think it's Hep B. And you normally get one, and then you'll get a booster, and then you'll get another booster, right? It's normally a round of 3 vaccines. And your children, of course, when you vaccine your children, they normally get a lot of the vaccines are a group of 3. They'll get one, and they'll get one, say 6 months later or whatever, and then they'll get another one maybe a couple of years later. So just be aware of that. Artificial passive immunity is, like I just said, when you're moving it from, say, mother to fetus via the placenta or through the colostrum or the breast milk, which would be your secretory IgA. All right, it's a lot, yeah? Immunity is a lot. We're nearly done with this chapter. You guys are doing awesome hanging in with me. Cell-mediated immunity is what? Which cells do the cell-mediated immunity work with? Your B cells or your T cells?
B.
Who said B?
Am I wrong?
T cells.
Yep, that's what I meant.
Okay. Remember, mediated. T.
With the T. Got it.
With a T. All right. So these, they're called natural killer cells, which I love that term. It's a great term, right? Natural killer cells. And it says right here at the bottom, you've got your helper inducer T cells. These are your T4 cells, by the way. And also these are the cells that is your CD4 cells, or cluster or differentiation for T cells. So CD4 cells, that's what you're looking for with your HIV or your AIDS patient, all right? That's what's dropping. So they recognize self versus non-self, okay? They help with overall immune function. The cytokines involved increase bone marrow production of stem cells. They speed up their maturation. They're more of a calling to arms type of T cell. That's what they do. They're like, hey guys, we need you, come on board, help do what you got to do to get this immune system up. And then you've got CD8 cells as well, which are more of an inhibitory factor. And then of course you've got your cytotoxic T cells, and I'm not going to go, and then you've got your natural killer cells as well. So you've got several different types of T cells, but the ones I really want to focus on more are your CD4, your T4 cells, because those are the ones that sort of have a focus with HIV and AIDS. And I say they're protective. So you take away that protection, and that's why these patients are more susceptible to pneumonias, also to different cancers like Kaposi sarcoma and things of that nature, because you've removed that protection. Cytokines down the bottom there on page 299. Again, we've got many, many, many different cytokines. And on page 300, it talks about some of them. Your interleukins, your tumor necrosis factor, your growth factors as well, like GCSF, erythropoietin, thrombopoietin. So all these different cytokines, and there are many, many more than these, work together to sort of help with an inflammatory response. So we want the cytokines, but then of course the issues occur when we have much cytokine response, and that's a whole nother story for another day. But I just want you to bear in mind, of course, that there is a balance between the cytokine response, them going, yep, we're going to fight this infection, but then of course we run into problems, which is a little bit with the COVID thing. That's part of the problem. You've got the cytokines coming in, and if anybody is sort of read a little bit about that, but that's part of the problem why people die. It's not so much that the virus itself, but it's the cell-mediated response they're saying is part of the issue, that the body has this massive response of the immune system that overpowers everything. Has anybody heard about that? Read about that at all? Or that's one of the things that they're thinking could be an issue. No, you don't find that exciting? I think that's sort of exciting. All right. Anyway, but be aware as well, these cytokines are wonderful because they can be used as what? Growth factors. We can use GCSF for what? It says right here, increasing numbers and maturity for neutrophils. We also use epogen. Here it says erythropoietin, but epogen is another form of it, helps increase those red cells. That's great for those cancer patients, right? Or those patients that had their immune responses knocked down. Okay. Lastly, I just want to talk a little bit about transplant rejection. And let's see, transplant rejection. I thought there was something on your HESI. Oh, please be aware, CD4 count and HIV was a HESI question. All right. So if you weren't listening to me when I talked about that just now, you may want to go back and read it or listen to this video later. But CD4 count, HIV was on it. Okay. Let's see what else I want to talk about. I thought there was something about transplants. Can't find it. There is something about immunity and vaccines. So again, be aware of that. And anybody know what the herpes zoster vaccine is called or for?
Shingles.
Yeah, it is. It's called Zostavax, I think.
Yeah.
Yeah, Zostavax. But I did just want you to be aware of that because that actually is was on the last HESI, all right? So vaccines, immunity, those types of things are actually more important than we think they're going to be when it comes to the HESI. All right, one other thing, and CD4 count as well. Please be aware of that. Let me see, a couple of other things. Rejection. All right, and I'm not talking about emotional rejection. I'm sure we've all been exposed to that at some point or another. However, let me see what I want to say about rejection. And then I'm going to talk about skin, and we'll be done. Who did I say would be the best donor for an organ if a patient was having a transplant?
Twin.
Yeah, identical twin.
Identical twin. Thank you. Identical twin. Exactly. All right. So basically with rejection, I think having talked about immunity and the body's phenomenal ability to recognize non-self, what do you think occurs when we put something foreign in our bodies, even if we want it to do that?
It rejects it. It fights against it.
Yeah, absolutely. So there's several different types, these natural killer cells, and the T cells are the ones that go into action and go, oh no, you don't belong in this body. So they're going to go into action and start a fight to basically reject that body. It says right here, hyperacute rejection happens immediately after that organ or whatever has been put in the body. Bear in mind, of course, this is why we also look at the HBO testing as well on our blood, right? Because in part, we're looking at a rejection of the blood when you give the wrong blood product. Acute rejection occurs 1 to 3 months after transplantation. Chronic rejection, this can occur anywhere past that time frame. It's a major cause of death in patients who have survived 1 or more years after a heart transplant. So all these patients that have a transplant of some form of another have to be on medications that suppress those cells, right? They're suppressants. So we're looking at on page 302, it just gives you many, many different types of medications. Like
Excuse me.
cyclosporine is a big one that's been used forever. Steroids, of course. Cellcept is another one. There's many, many, many different ones there, and I just want you
So
to be aware of
those
it.
medicines are used then to suppress the T cells.
Exactly, because logically, as much as those T cells are doing what they think they should be doing, we don't want them to do that, right? We want
Right.
to suppress them and say, no, 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 this is meant to be happening. We want this organ, so just go away.
Okay.
All right. But the problem is with these anti-suppressant meds is, one, the patient has to be on them for life. And two, what are we doing? We're suppressing their immune system, right? So they're still going to be at risk for many other issues. So just be aware of that. Steroids, of course, and all these immunosuppressive type of medications allow the patient to be at a higher risk for infection. Okay, does that make sense? Clear as mud, I bet. Okay, chapter 25. This is a little easier of a chapter. We went over a lot of this on Tuesday, so it shouldn't take too long to go through it. So we already, on page 449, we already talked about best practices for skin and preventing pressure injuries. And as I said, on our watch, we never want to be the cause of a pressure injury, right? We never want to be that nurse that has left the shift and the next nurse comes on and she's like, oh my gosh, what the heck has gone on here? So different things can occur to create pressure injuries. And I want you to be aware on the top of page 449, how to prevent pressure injuries, right? We're looking at positioning, different ways of positioning. You're not going to slide or scrape that patient and cause shearing or friction. We no longer place a rubber ring or donut under the patient's sacral area. Don't know if you guys are aware of that, because it actually just creates pressure elsewhere. We're going to move our patient every 2 hours. Maintaining fluids, maintaining hydration, maintaining a good diet, daily inspection of the skin. I know you guys brought out a lot of these pieces yesterday, and great skin cleaning as well. I think we already discussed the Braden scale, and as Mimi and a few of the others noticed, there can be variations, just slight variations, but variations in the Braden scale, and what actually means severe or moderately severe. The bottom line is, I mean, my goodness, you know, hopefully we're not getting too severe. I think I went over the fact that the prealbumin is something we look at, and albumin. That's on page 451. So prealbumin, if it's less than 19.5, and albumin less than 3.5 are things that we want to look at and be aware of for our patient. Let me see if I have a question for you. I think I do. After teaching a patient who is at high risk for a pressure ulcer, what dietary choice by the patient indicates a good understanding of the teaching? Low-fat diet with whole grains, cereals and vitamin supplements, a high-protein diet with vitamin and mineral supplements, a vegetarian diet with nutritional supplements and fish oil, or a low fat, low cholesterol, high fiber, and low carb diet? Which one would
High
be the
protein.
best? High protein. Yes. Yes, yes, yes. All right. We were just talking about protein. So, so looking at patients that would be a high risk for developing a pressure sore, would a 46-year-old on antibiotics, would a 24-year-old who's bedridden with a fractured leg, would a 68-year-old who's got a hemiparalysis and incontinence, or would an 80-year-old requiring assistance to ambulate with a walker? One would be the highest risk for a pressure sore.
Just give me two. What was 2 and 3?
Number 2 is a 24-year-old who's bedridden with a fractured leg, or a 68-year-old with hemiparesis and incontinence.
I think it's 3.
It is 3, and I'm going to tell you why in a minute. Incontinence. It's a huge, huge issue, all right? So incontinence is one of the substances that irritate the skin, destroys skin integrity, and predispose to skin breakdown. You've got urea, you've got bacteria, you've got yeast, you've got enzymes in the urine and the feces. So basically, incontinence is a massive issue that needs to be taken care of, right? Looking at different support services and support devices that can be used. I mean, of course, the biggest thing, we want to turn our patient every 2 hours, but we can use lots of different things. There's lots of beds out there. There's lots of devices out there that are static or non-static that we can use to prevent any type of pressure injuries. What I do want to bring out though is it does say turning every 2 hours, but honestly, that's the maximum. We really want to be turning and moving our patients more than that if we can. Okay, just to bear that in mind. Let's see. All right, moving on. Can anybody tell me how many stages on page 452? It shows not just 4 stages. How many stages does it show there? How many, not just stages, but how many types of pressure?
You said 452?
452.
6.
Yeah. Yeah. So although we've got stage 1, stage 2, stage 3, and stage 4, we also have our unstageable, right? And we also have our DTIs, deep tissue injury as well. So I want you to be aware of that, because just because it is stage 1 does not mean that they're already in the deep weeds with a deep tissue injury. Okay, so please be aware of that. I don't think I need to go over a lot of wound assessment. I think we covered that in depth on Tuesday. Do you feel we covered that with wound assessment? Yeah, looking at cellulitis. The only thing I would bring out is eschar. Does anybody know what eschar is? It's in the book on 453.
It's like the layer over.
Mm-hmm. What color?
It could be black, gray, or brown.
Yeah, yeah. It's that eschar, really necrotic tissue that's dead. Okay, and what they usually do is you're going to see your eschar as something like maybe a stage 2, maybe stage, well, really the unstageable, because you can't see under it. And at that point, they may go in and debride that area so that you can see what's going on under there and start to heal what's going on under there. Okay, so bear in mind Eshkar, bear in mind undermining. Undermining is something that you might see as well, where you've got your wound, but it's actually under that area, if that makes sense. Maybe that doesn't make sense what I'm trying to say there. If you look at page 454, you may see a little example of that. Well, E is Eshkar. You'll see the Eshkar there on E. And D shows you some examples of undermining. It's sort of hidden. You can also get tunneling as well, so be aware of that. So at the bottom of page 455, I want you to be aware of what we mentioned yesterday, colonization. So colonize wounds, like I said, on our skin, but the problem is when we get too much colonization, that's when you get these biofilms occur, or more biofilms. And it says it right here, pathogenic organisms form biofilms that lead to wound infection. So that's really the problem. The colonization is pathogenic in of itself, but these biofilms occur, and that's what really causes wound breakdown and impedes normal wound healing. All right, so I just want you to be aware of those things. And then, so what are we going to do? We're going to swab the culture. We're going to swab the wound rather, and see what it cultures, and that allows us to hopefully treat the wound appropriately. On page 456, there is the most beautiful concept map that I've ever seen that shows a concept map of tissue integrity, a pressure injury, what has occurred with that pressure injury, and on and on and on from that. What we would like to see as an outcome. It would be wonderful if we could see an outcome where the patient's pressure sore is reduced in size and that the patient doesn't develop any more of them and that his infection is actually resolved.
Did you
So
say
what are we going to do for
454?
that? Beg your pardon?
Did you say 454?
456.
Thanks.
You're welcome. So we're going to do a lot of different things for wound infections, right? So let me see. Question for you. So if a patient has a wound infection, we think they might have. There might be 4 different types of things that give the nurse an indication of a wound infection. Would it be patient with blood cultures pending? Would it be a patient who has thin serous wound drainage? Would it be a patient whose wound has decreased in size? Or would it be a patient with a white cell count of 25,000?
White blood count of 25,000 is. Well,
Yep, 25,000 because that leads.
Yeah, that's high.
Yeah,
Right.
leukolytes, not leukolytes.
Yeah.
White blood
So
cells.
remember what I talked about, right? Your body is trying to respond to a foreign body or to an infection by bringing those white cells to that area. Okay? Good, good, good. All right. Give me a second. Let me see.
How about ask that question on the test?
Hang on. I had another one that I want to give you guys. Oh, I'll keep going. Bear with me. Oh, I can't find it. Oh, well.
Did you say something about the chart on the bottom of 253? Because it's like great.
At the bottom of 253, thank you. I did want to bring that out. Colonization it says types of wound exudate. And I just want you to be aware of the different types of infection that just by seeing the types of pus, you can go, oh, that looks like this. Oh, that looks like Crohn's. Oh, that looks like C. diff or whatever, or staph. Okay? And at the bottom of table 25.1 shows you like creamy yellow pus, probably staph. Green, blue pus, it has a very distinctive smell, Pseudomonas, and on and on and on. So I just wanted you to be aware of those different types of things. All right, wound management. So what are we going to do? Well, there's lots of different things. There's 50,000 different types of dressings that can be used. Like I just said, depending on the fact if you've got eschar there or necrosis, they may debride that dressing first, because you can't really put a dressing on something that's already dead, right? Makes no sense. You've got to debride that area, scoop it all out, scoop out all the junk first, and then you can start putting some of these designed dressings that they're going to use. And there's many different types. There's the non-absorbent dressings if something just needs protecting. There's the hydrophilic absorbent dressings. They're not gauze. We do sometimes use the wet to dry dressings a lot of the time for healing, but there's a lot of absorbent dressings that are used now to help really clear up some of the gunk that's going on in there and help and pull it out, literally like an osmotic type of effect. So at the bottom here, there's some different types of dressings that it is there. But I just wanted you to be aware of it. Of course, we're going to do all the other things we just talked about, try and get that patient up, nutritional therapy, physical therapy. We can use things like negative pressure wound therapy, our wound vacs. But it does say as well, wound vacs, although they're great, they can cause some damage, and I do want you to be aware of that. On page 258, there's a nursing safety priority. So be careful with your patient who's on an anticoagulant. You could cause a lot of bleeding with that patient and actually cause more damage. So just be aware of that with those types of patients, okay? And let's see what else I want to say. Hyperbaric treatment is often used. Growth factors can be used. Some of these plant-based gels, they're more like a colloid, or there's some of them from seaweed as well that can be used, and more like a stringy type of thing. I'm sure either Mimi or Rhonda, you working in, I want to say Select, but it's not, Cure Health. You probably see a lot of that type of thing being used, right? Do you see different types of dressings used for your patients?
I do in
Yes.
long-term care, but I don't know about Rhonda.
Okay. Okay.
And we have an actual wound nurse that's their primary job, except for on the weekends.
Do you have a wound care nurse?
Yeah, I do. At the nursing home, there's a wound care nurse that comes through and that does wound care daily, like Monday through Friday. And then a doctor comes once a week, just to walk with her and go over the patients that had like the most critical wounds.
Yeah.
And then we, as the regular nurses or whatever you want to call it, would do just regular wound care as needed, like PRN if it fell off, if a bandage fell off or something during a shower or whatnot. So
Right. Okay. So, of course, you're going to assess your wounds, aren't you? On page 460, it talks about what you're going to be looking for with your patients with their wounds, yeah? You're going to, like we said before, redness, tenderness, swelling, worsening, those types of things, understanding different types of wound, whether it's an injury or whether it's some other type of wound, okay? Checking for foul smell, the actual pus, anything like that that's going on, necrosis, on and on and on. And then, of course, the labs, like we said, the white cell count, and of course, the patient's actual, their neurological effect, their vital signs, all of these things are what we're going to be looking at. All right. So I think we have talked about pressure sores a lot. I want to talk about some of the other pieces. So irritations are things like pruritus. Pruritus means itching. Xerosis means dry skin. Many patients that have certain types of skin disorders get into this itch, scratch, itch cycle, you know, where you've got some sort of allergic dermatitis or something of that nature, where of course it's going to make it worse and worse and worse and put them at risk for infection. So certain types of inflammation can be eczema, it could be contact dermatitis, it could be atopic dermatitis, right? Certain foods create it, chemicals, even stress can create it as well. So what is happening is a response to the allergen. You're producing histamine into the skin, and things like Benadryl can be pretty useful to help downregulate that histamine reaction, okay? With things like urticaria. Urticaria means hives, and hives occur depending on what the reaction is. It could be a urticaria that they might have an IgE response, which is like an immediate hypersensitivity response. You know, the shellfish patient, oh my God, I ate shellfish, and you know, they're suddenly breaking out in wheals and hives and everything else. Okay, so those are the types of things that I think of when I think of these histamine responses. But it could be something less as well. It could be a case of a patient who has allergies to pollen. All right, so just bear those things in mind. We might put them on steroids. Not necessarily the best thing to do, because although steroids suppress the inflammation, what else do steroids do?
Stop the itch.
Didn't know that was a question.
Well, remember I was talking about your patients where you give them steroids and it suppresses, it's doing what we want it to do. It suppresses inflammation because it's suppressing the response, right? But it can also lead them more susceptible to infection because we've suppressed the immune response. So yes, we're doing a good thing, but it can also be a bad thing. On page 463, it just gives a little key features of different types of dermatitis. Remember, itis means inflammation. Anything itis is inflammation, whether it's cholecystitis, sinusitis, dermatitis, it's inflammation, right? And so we can give things like antihistamines. Psoriasis is more of a autoimmune type of response. It's overstimulation of the immune system. It activates those T cells, okay? And what happens is normally the basal cells, the turnover is usually about 28 days of our basal cells on the skin. Unfortunately, with psoriasis, the rate is speeded up. So they're getting a turnover every 4 to 5 days. And that's why you see these plaques. On page 464 at the bottom here, you'll see these plaques, and that's what's going over this quicker turnover of skin. Signs and symptoms of cirrhosis, it talks about some of them there, the silvery white scales that have sort of irregular borders. Well, it says sharply defined, which they are, but they're somewhat irregular in my mind anyway. Obviously, it happens all over the body, but it happens in certain areas. It happens more on the sort of knees and scalp and the elbows and things of that nature. It can also exfoliate. It doesn't show it here, but of course that's more of a severe form of it. Pustules can occur as well. And of course, it can be very, very traumatic for the patient. So a lot of emotional responses, a lot of emotional support is needed for these patients. And we do different things. Again, we can do steroids. Of course, we're suppressing that immune response, which a lot of the time we need to do. That can be a topical steroid, or it can be a systemic one as well. Tar preparations are often used, forms of tar. This is like an old medication. Tartrazine, or rather tazarotene is used. Let's see what else. Zithranol is used, lots of different things like that. But basically their base is tar. There's also another one where the base is vitamin D at the bottom, and that's been used forever. It's more like a milky white substance that you put over the patient, and that's called calcipotrione. And you may have seen that used. It also talks about, let me see, I want to say vitamin A. Yeah, there's a vitamin A one as well, Tazorec, that's used. So there's lots of different creams. There's light therapy with psoriasis, and it can be a continuous light therapy or a pulsed exposure as well, different types. And then of course the systemic therapies that can be used, like I just said, the vitamin A. There's a type of tumor necrosis factor that can be used as well. It actually that inhibits the tumor necrosis factor. Biologic response agents that basically prevent overstimulation of keratinocytes, which is what's causing that rapid growth and rapid turnover of the cells. Let's see. And it says right here, most of these are given by IV, IM, or sub-Q. Yeah, again, with all of these types of medications, unfortunately, you are putting your patient at risk for infection. So there's a nursing safety alert here, which says if your patient has an infection, the doctor needs to know, so that they'll probably have to stop those medications, because you want the body to be able to respond to an infection. Does that make sense? Big question at the top here, 465. If a patient is childbearing or sexually active, there are a couple of these medications that are tetragenic. What does tetragenic mean?
Harmful to the
Basically
patient.
bad for the immune system, the reproductive system.
Yeah.
Bad how?
They can cause defects, cause birth defects.
Right, right. So here's a question for you. A nurse assesses a young patient, a young female patient who's prescribed tazarotene, all right, the tar-like one. Which question should the nurse ask prior to starting this therapy? Do you spend a great deal of time in the sun? Have you or your family members ever had skin cancer? Which method of contraception are you using? Or do you drink alcoholic beverages?
Which method of contraception is she using?
Exactly. Yep. Because these medications are what? Tetragenic. Okay.
So, like, true story with that was that my daughter had an acne medication that had been prescribed to her that was tetragenic, and when I had pulled up to the pharmacy to receive this medication, it was like a $600 medication, and it was just for topical, it was for acne and everything, and because she has eczema and everything. And then when I pulled up, the lady says, and she had to be like 11 at the time, 10 or 11, and then the lady says, what kind of birth control is she using? I said, excuse me. I said, she's 11. Like, what are you talking about? Birth control. And so then the lady went into, and mind you, I'm a nurse, so I had no idea about it. But the pharmacist went into detail about how it could affect. I said, well, she's not even sexually active, so go ahead and let me get that. So.
Yeah, there is, and I can't remember the off the top of my head, the medication for acne where the patient actually has to, I want to say Accutane. I think it's Accutane. They have to sign, it's called iPledge, and it's a monthly thing that has to be signed to say, you know, whether they're on birth control or not, whether they're pregnant or not. It's a big deal. It's a big deal. So, and unfortunately, even at 11, I hate to say it, but you know, there are there are children out there with lots of different circumstances. So, you know, I hate that she had to ask that question, but all right, skin infections, bacterial infections. So on page 466, there are pictures of a lovely furuncle. Has anybody ever had to lance one of these?
Yes.
Yeah. Don't they smell?
Sure do.
Yep, they do. And that is staph that causes that lovely smell. And it talks about it right here. Folliculitis, you know, that's going to be a small one, but the furuncles, these furuncles can get pretty darn big, let me tell you. And then develop into what's called cellulitis. So usually it's through staph, sometimes it can be strep. So just be aware of that, of what it looks like. And what is staph? Well, Staphylococcus aureus is, of course, our lovely bug called MRSA. So a nurse who manages patients prepares to place 4 patients on a med-surg unit. Which patient will be placed in isolation awaiting possible diagnosis of infection with MRSA? Patient admitted from a nursing home with furuncles and folliculitis. A patient with a leg cut and other trauma from a motorcycle accident. A patient with a rash noticed after participating in a soccer game. Or patient transferred from the ICU with an elevated blood count, white cell count. Who said that? The first one?
Mm-hmm.
Good. Yes. All right. Okay, so key features of your skin infections. Well, there's a whole bunch of skin infections going from, like we just said, cellulitis to herpes. There's herpes 1, there's herpes 2, there's herpes zoster, of course, which is derived from chickenpox. There's dermaphytes, which is your fungal infections. And then we've got candidiasis, which of course is your yeast infections, okay? And so if we turn to page 468, pretty picture of a herpes zoster. And herpes zoster goes in what's called dermatomes. It doesn't go across the whole body in a diffuse manner. It will go in a line. I might sometimes see it on somebody's face, on one side of the face or one side of the body. So just be aware of that. It does talk about, it talks about anthrax. I mean, really, on the grand scale of thing, you're not going to see that many patients with anthrax. But if you do, it looks like what it looks like on page 467. And
that is a mark that never goes away. Ugh.
Yeah, and be aware that you're going to be on antibiotics for at least 60 days. So, so there you go. But, there's many skin infections that leave a mark forever. But, yeah. Have you seen, Mimi, in the military, anybody anthrax or something?
I have one. I have one.
You?
Yes, ma'am. I have one.
You got exposed to anthrax?
No. We have to get the anthrax vaccination. We have to get a bunch of vaccinations because we go to country. So when they gave us this vaccination or whatever, it leaves a ugly mark. Just the vaccination itself leaves an ugly mark on our bodies.
I see what you're saying. Yeah. Is it a little bit like my BCG and my smallpox, probably similar? It does the same thing.
Right.
You get a blister, then it blisters up and scabs and all that stuff. Yeah. All right. Well, we're twins. We've both got these. All right. So herpes 1. Herpes 1 is the mouth sores that normally it's a virus. So although you may not see it again, it's still there within the body. And then of course herpes 2, HSV2 is the genital area usually, and of course reinfection of that can occur as well. So and then herpes zoster is your shingles. it's a reactivation of somebody who may have had chicken pox, and not always, but that can occur. And a lot of people get what's called post-hepatic neuralgia, very, very painful for people. I like to use like the pain patches, the lidocaine patches are pretty good for those types of patients as well. So let's see, what else did I want to
I
say?
had a doctor who would use gabapentin or Neurontin also because it affects the nerves.
Yes, absolutely. Yep, that's a good one too. Let me see. Yeah, it's just saying that herpes can be contagious to people who haven't had chickenpox or haven't had the vaccine. I think that's pretty self-explanatory. All right, fungal infections. All right, well, anything with tinea, Tinea, is a fungal infection. And after it, it will say things like, oh, tinea pedis. What do you think that might be? Foot fungal infection, right? Tinea corporis, body infection. We may see it there. Tinea cruris, which is the groin infection. Tinea capitis. That's, you know, the scalp. And tinea corpus by anyway is ringworm. So those, I just want you to be aware of these different types of fungal infections that occur. Candida is a yeast infection. You may have seen that says oral candidiasis or thrush, as it's often known. Happens a lot with people that are on antibiotics or diabetics or people that just be aware of that. And of course, health promotion, preventing the spread of MRSA. We talked about that yesterday, what we would do about that. There's a nice little box all about that, excuse me, at the top of 469. And there's lots of things that we would do about that. And then, of course, that goes for your fungal infections, your candida. It's making me itch right now. That we would do, of course, excellent hand washing, avoiding contact with bedding or anything with these patients, making sure they understand within the family as well how to not infect their family members. So and it says right here, priority nursing interventions focus on patient and family education to prevent infection spread to other people or other areas of the body. The most effective thing is great skincare with proper cleansing and all of that. Let's see, talks about staph infection. Of course, we're going to isolate our patient, aren't we, if they are exposed to a staph infection. It's one of the things we have to do. Some of the medications that we can give for our MRSA in patients are things like, I think I may have touched on this a little bit yesterday. It could be a mild infection where you could do either topical or oral, but you may need to go with the big guns and do some IV antibiotics such as IV vancomycin might be used, or clindamycin, acyclovir. Acyclovir, valcyclovir, and famciclovir, they're often used for your herpes and also your herpes zoster as well, okay? The dermaphytes or yeast infections, usually you're going to use an antifungal cream of some description for those. Talks about parasites at the bottom here. Pediculosis is a lice infection. So I just have a story for you. I know it's getting on, but when I first came to the States, I worked as a home health nurse in Ocala. And, you know, it was very interesting because I'd never had that experience. Now, it's making you itchy, Lisa. And I went into these little trailers and things and fish camps, and my job was working in the Ocala National Forest. That was, so I had a Ford Ranger pickup truck, and I would go around the forest visiting all these patients. Well, I came home one day, my hair used to be really, really long, down to here, but of course I always wore it up. But I was like, what? Why am I itching like crazy? I was like scratching and itching, and I'd never experienced this before. Well, I'd got lice from one of these, you know, I'd gone to somebody's home, sat down in one of their chairs and talked with the patient and got lice. So you can imagine lice in this mop, right? Can you imagine how that was? Wow. Yeah. So anyway, yes, I'm very
You figured it
aware
out
of,
that day, right?
beg your
You
pardon?
figured it out that day.
Yeah, what you know, and I was like, what are these little what you know, I'd never come across that before in England, you know, and I just moved to Florida, and I think it's probably more prevalent in warmer climates. So anyway, figured that out pretty darn quick. So pediculosis capitis, yes, occurs more often in people with longer hair. Certainly did with me. Anyway, of course, we use all these different things. There's Emilite and Lidane, and there's a million different products that you can put on the hair and on the body to get rid of these nits and these lice and things like that. Okay, so I think you're pretty much aware of those. Would you say you've heard of that? Yeah,
Yeah.
Elisa's nodding. Yeah. And then, of course,
Yeah.
we've got scabies, unfortunately, which burrow under the skin. And there's a picture of that on page 471. And infestation is confirmed by a scraping of the lesion. Let's see if I've got any questions. Oh, yes, maybe we do. Okay, so based on that picture, a nurse assesses an elderly patient who's scratching and rubbing white ridges on the skin between the fingers and the wrist, which is often where we'll see these. What action would the nurse take? Place a patient in a single room, administer an antihistamine, assess the airway, or apply gloves to restriction?
Place them in a room.
Yeah, give them all so.
Yeah, very, very contagious. And as I say, you'll often, and it says it right here, examine the skin between the fingers and the palms. You'll often see them in those types of areas. All right, we are almost done, ladies. I promise you a few more pages. Try and get through this quickly. Bed bugs, I don't really need to go into that. Let me go on. I just want to, on page 473, I just want you to be aware of different types of healing. Healing by first intention, healing by second intention, and then healing by third intention. And it just shows a nice little staple line here and the stages of healing, as you can see. And wound healing can actually take take a couple of years actually to really heal properly. But anyway, first intention, it says wound edges are brought together with the skin layers lined up, or as it's really called, approximated. So when something is well approximated, it lines up well. There's no gaps and no overlaps or anything like that. So that's the first intention, and that is where wound healing is just starting. And on page 472, it shows you that beginning of the wound healing. Second intention, you're beginning to get that granulation occur and beginning to get an epithelium over the scar. And then third intention, it's talking about the fact that sometimes if there's an infected wound, they may have to leave that wound open, okay? So that wound may have to be left openly as a wound to allow for the skin, to allow for the infection to get out of the body. And you can see there that they've actually sutured the wound, but it's still open. So I just want you to be aware of that. Let's see. I don't think I have anything that I'm not really going to talk. I do want to go over on, let's see, skin cancer. Skin cancer, page 475. Please look at the pictures for skin cancer. I want you to be aware of the different types of skin cancers. On page 475, it talks about the pre-malignant stage, which you may see you little old people with what's called actinic keratosis, they're pre-malignant ones. Then you might see a squamous cell carcinoma, which is depicted here on page 475. You may see a basal cell carcinoma. Please look at that on page 476. It looks like a little white pearly look. I will want you to know what that looks like. And on page 76 below it, a melanoma, okay? And so basically what we're looking at is the fact that these skin cancers are fairly obvious because they don't look like a normal mole, right? Their borders are irregular, the color is usually irregular. They just don't look normal at all, right? They're not normal in their shape, in their depth, in often they might have some bleeding to them, they don't heal properly. All of those types of things are what we notice with our skin cancers. And so what are we going to do about it? Well, we're hopefully going to teach the patient to prevent skin cancer. On page 476, it talks about the things that we can do to prevent that. Let's see, what else do I want to bring for you? I know. Yes. Hang on. I'm looking to see if there's any others I want to really. I think we covered a lot of it. All right. Let's see. Incidence and prevalence. Incidence of skin cancer is highest among light-skinned races and adults older than 55. And of course, people that work outside a lot, right? Of course, they're at higher risk. People as well, occupational exposure, depending on where they're working, can be a cause as well. Best thing we can do is early detection, which is secondary prevention. Primary prevention is truly preventing it from happening in the first place. All right, this is secondary prevention. They've got the issue, we've detected it, and now we've got to make sure it doesn't get worse. We're going to talk about, well, you know what, the ABCDs. We don't actually talk about burns or anything of that nature, but I do want to just, the ABCDE guide for melanoma. Has anybody ever looked at that at all? And I just want you guys to be aware of that. ABCD. We do talk about that assessment further on, hair, skin and nails, chapter 24. I will be doing that one, but not today. All right. Different types of things that we can do for our management. Of course, there's chemo and radiation. Patient might need surgical management, like a Mohs procedure, where they excise basal cells and squamous cell carcinoma. They actually take it off in layers, and then they send off for histology for those types of moles or whatever is going on there. Different types of medications. 5-FU cream can be used. Imimicod cream can be used for basal cell carcinoma. Of course, IV chemo, cisplatin, 5-FU, which is one of the older medications. Biotherapy can be used. Again, these interferons, these monoclonal antibodies. What these do is interferon is like an interleukin, so it just helps upregulate the immune response and attack that cancer, those cancer cells that are occurring there. So again, it talks about it there. Monoclonal antibodies leads to greater T cell activity, and they're going to attack those cancer cells on the body or wherever they are. Let's see, and then of course radiation. Radiation really is more for your older patients now, but I just wanted to bring you aware of it. Finally, I would say this is something that is really important and it's dear to my heart. If you turn to page 478, you will see Stevens-Johnson syndrome. Now, any of these types of syndromes, this one is also called toxic epidermal necrosis syndrome or Stevens-Johnson syndrome, or in the case of my father, bullous, he had like a bullous type of infection. But all of these types of infections that you might see, please, please, please be aware, it is deathly to the patient. These types of things are potentially deathly to the patient. It's a toxic drug reaction that is occurring systemically. And be aware that this isn't just occurring on the outside of this patient's body. It's occurring on every organ, inside their mouth, inside, you know, all the way down the GI tract, all the way inside their body. So please, 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 if you see somebody developing these types of skin reactions, jump on it. It says it's life-threatening, okay? And it is. Yeah. So if it doesn't get taken care of quickly, the patient will die as a result of this, okay? So on that note, I think we have covered a whole lot of stuff. What do you think?
Yes, ma'am. Yes, ma'am.
Yeah, too much to digest at one time, definitely.
Okay.
So you all know that we're gonna this afternoon. I'm gonna do one-on-ones with each of you for half an hour, starting at. Let me look up the first one. Bear with me a second here. I want to say who's first at 1 or 2 or something.
I'm at 2.
Kaylin. Kaylin is at 2. You're the first one. So Kaylin, you're at 2. Elisa, you're at 2:30 on Teams. Rhonda, you're at 3. Evelyn, you're at 3:30. And then Mimi, you're at 4.
Yes, ma'am.
All right, guys.
Okay.
I will be with you all afternoon. I'll probably need little breaks, but okay, I will see you, Kaylin, at 2 on this. All right.
Ma'am.
Any questions so far? I'm sure we'll have a lot on our one-on-ones, but I'm going to let you go because I kept you a little late. Okay.
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 Ma'am.
Bye.
All right,
Bye.
bye-bye.
Thank you.